Okay, good morning, good afternoon, everyone. Welcome to another Limi cardio care webinar series. Today, the Limi Children's Hospital will be hosting us. Dr. Peter Igoche is a consultant pediatrician and a pediatric cardiologist. He is flanked by Dr. Kefas Gibere, a consultant pediatrician, and Dr. Alba Suberu, who is also a consultant pediatrician, a pediatric cardiologist. They are attending to questions that are coming up from the webinar. So if you have any questions while we are going on, you can just write them in the Q&A tab, and straight away, I assure you it will be quite an interesting and very rewarding time. We expect to spend about 60 to 75 minutes. I want you to invite your friends, people that are not here, send them the link, let them register. Let's so that we will start. We'll be starting in exactly 2 minutes. We'll start in exactly 2 minutes. The other topics that have been discussed so far include things like we have discussed chest pain, approach to chest pain management. We have discussed approach to difficulty in breathing with a focus on COVID. We have discussed hypertensive crisis. We have discussed COVID and pregnancy and how to deal with COVID and pregnancy. And today we are discussing shock in children. Next week, we'll be going back to cardio care and we'll be discussing diabetes mellitus. We will be discussing an aspect of diabetes mellitus, so keep your questions handy. Shortly, after that, we'll probably go towards hypertension again or heart failure or something like that. Likely going to be industry sponsored, so we can reach a larger amount of people. I think those people that have joined so far have been benefiting a lot. We've got quite a lot of fantastic reviews. We have over 62 people joined up now from around the country: Ilorin, Ibadan, Sokoto, Lagos, Port Harcourt, Delta, Kaduna. So we're very happy to host this. Limi Hospital was founded in 1982 in Zaria, and we are pleased to give some of what we have to the medical community. That is Limi Children's Hospital you are seeing on the screen there. And shortly, Dr. Peter will be starting. Limi Children's Hospital is focused on pediatrics. It's a 26-bed facility. The NICU is about 5-6 beds, incubators with ventilators, CPAP machines. We have a 5-bed emergency ward, multiple beds. We have full-time consultants who are joining us and giving part of their information today. And we'll do quite a number of things there. It's located in Wuse to Abuja, and right there we'll be going. So straight away, we'll start now. Dr. Peter, over to you.
Okay. Good day, Dr. Igoche Peter. I'll be presenting shock in children, diagnosis and management. I'm a consultant pediatrician and pediatric cardiologist with the Limi Children's Hospital. By way of the outline, I'll look at the introduction to shock in children, and then we'll discuss types of shock we have in children. We'll look at cardiovascular adaptations, the basics, then take the various shocks, shock types, and manage each of them, then we conclude. Now, shock is actually said to be the clinical manifestation of cellular hypoxia that occurs as a result of insufficient perfusion or inefficient perfusion, insufficient circulation or inefficient perfusion. Now, it's a pediatric emergency and results into, it's an acute emergency that occurs because of failure of delivery of adequate glucose substrate. Of course, I said insufficient circulation. Now, if there is insufficient circulation, substrate delivery is deficient, oxygen delivery is deficient, and then ultimately results to mitochondrial failure at cellular level. Now, with all this definition, how do I get to know when I have a child in front of me who has shock? Well, basically, we look at 3 basic systems for us to hit our diagnosis. Now, the cardiovascular system, well, we know that generally examination of cardiovascular system is said to progress vasculocardiac. So you move from the periphery. So the capillary refill time, which is the most distal aspect of the examination, realize that normal capillary refill time should be less than 2 seconds. But when you meet a child in shock, capillary refill time is greater than 2 seconds, that's 3 seconds and above, there are pulse abnormalities, commonly increased pulse rate. Although I will bring up one type of shock where we have bradycardia. We'll take note of that when we get there. Now, pulse volume is commonly reduced, but note again, it could be bounding. Now, there are blood pressure changes. I wouldn't talk much about that now in the next few slides, but we'll talk about cardiovascular adaptation in children with shock. So, in the cardiovascular system, we look at the pulse, the blood pressure, the capillary refill. Now, these are actually vital organs, you know. The central nervous system, there's altered mental status. The Glasgow Coma score for that child is obviously going to be less than 15. And because there is problem with circulation, problem with perfusion, the kidney suffers. So urinary output is usually going to be less than expected. It's usually below 0.5 mils per kg. Now, it's important we bear this concept of recognizing children in shock at heart as we progress through the various kinds of shock. Now, first of all, let's just quickly look at the stages of shock, because this discusses the severity of shock, and all children, you may meet them at various stages. Now, at the initial phase, the problem is a problem of circulation. So cardiac output is reduced. If cardiac output is reduced, perfusion is reduced. So we have hypoperfusion, and that's why you could find easily decreased capillary refill time at the extremities. When capillary refill is reduced, decreased perfusion, there's also decreased supply of oxygen. So normal metabolic pathway, the glycolytic pathway that ordinarily would have led to over 36 moles of ATP, will be switched to anaerobic glycolysis, and you get very, very low glucose level, so heightened anaerobic glycolysis. At this stage, well, it's easy to reverse. Now, but what happens if it's prolonged? Compensatory mechanisms set up. So you could find the child in shock or compensated. However, compensatory mechanisms do not last too long. It will just take a few minutes to a few hours. At this stage, shock is still reversible. We could still come back to normal Glasgow Coma score, normal mental status, normal perfusion, if adequate care is given. If not, when compensatory mechanisms fail, the children get into a decompensated state. That is bad. And we do not want the refractory stage, because we said in our definition there is mitochondrial failure and ultimately cell death, causing dysfunction of multiple organs and ultimately death. Now, what are the cardiovascular adaptations we talked about? We are looking at them, just the basics. Compensatory mechanisms. Because circulation is reduced from a reduced cardiac output. By the way, we remember the hydraulic equation of cardiac output being the product of stroke volume times heart rate. Now, well, in adults, both the stroke volume and heart rate could be modified, could increase to compensate for cardiac output. But for children, heart rate will be the only parameter in this equation that would increase. So we said that in their pulses, pulse rate increases. So pulse rate increases to compensate for increased cardiac output. This is going to last for just a while. Now, there's going to be shunting of blood. Remember, again, there is hypoperfusion. So blood will be shunted from less vital organs like the skin, and again, explaining why we have decreased capillary refill time, to more vital organs such as the kidneys and the brain. Now, we'll bear that in mind, perfusion. If circulation is reduced, cardiac output is reduced, mind you again, blood pressure again is equal to cardiac output times total peripheral resistance. If we have problem maintaining cardiac output, obviously, blood pressure gets to drop over time. But if it is well compensated, that's why we said blood pressure changes vary. We could meet the child at the point where the blood pressure is still normal, or the point where blood pressure is low. We want to prevent dropping of the blood pressure, because the compensatory mechanisms, like I said, will last just a few minutes to a few hours before they fail. When compensatory mechanisms fail, shock moves from the compensated state to the decompensated state. Now, the child gets into critical hypotension, badly enough, ultimately cardiac arrest. Because we mentioned blood pressure, I just want to put up this slide to emphasize something. We deal with children and not adults, so we do not use the blood pressure cutoff of 120 systolic and 80 diastolic for babies. Now, the American Heart Association 5th centile for systolic blood pressure, according to age, is as displayed. Now, for neonates, we want neonates to have a neonate having blood pressure systolic of 60 millimeters of mercury is at the 5th percentile. We do not want it to drop below that level. Now, for infants, 70 millimeters of mercury. Now, as a rule of the thumb, for babies between 1 year to 10 years, this formula is here. Now, looking at the formula before you, let's take, for example, there's a child who is 5 years old. So I say age in years times 2, that's 10. Then 10 plus 70, that's 80 millimeters of mercury. So for the child who is 5 years at 5th percentile, rule of the thumb, we expect 80 millimeters of mercury. Now for children more than 10 years, systolic of more than 90. Now, if we find a child in shock with systolic blood pressure more than the American Heart Association 5th percentile, that child is compensated. That is what we want. But shock, I will let you know that shock can be reversed at this stage. However, it is ominous. It is bad. If the values fall below the 5th percentile, they decompensate. So it progresses to irreversible shock, cardiovascular collapse, and ultimately cardiac arrest. Well, let's look at for the purpose of this presentation, we are sticking to this classification. We are aware that there are other classifications. Other classifications try to separate septic shock from the distributive shock, where I lumped it, and others also try to separate and they put a class of anemic shock separate from hypovolemic shock. However, we're looking at hypovolemic shock, distributive shock, cardiogenic shock, and obstructive shock. So let's start with hypovolemic shock. The problem here, there could be loss of fluid in terms of fluid from the gastrointestinal tract or blood from the circulation in children with hypovolemic shock. Now, if it is what we commonly see, diarrhea, vomiting, or children who come with burns or third space fluid losses, these children will have decreased cardiac filling. So when cardiac filling is less, because the central circulating blood volume is less, cardiac filling is less, and diastolic volume, the amount of blood that gets into the ventricles at the end of diastole, is reduced. And if it's reduced, the stroke volume is reduced. Now, mind you, cardiac output is heart rate times stroke volume. So when stroke volume is reduced, you follow Frank Starling's curve, automatically cardiac output is reduced. Now this is a link from the loss of fluid in diarrhea to shock, where ultimately cardiac output is lost. Also, children who have trauma, maybe road traffic as trauma, surgery, who lose some significant amount of blood, or from gastrointestinal bleeding, we see some children who probably have taken high doses of non-steroidal anti-inflammatory agents on empty stomach, who bleed into the gastrointestinal tract. Now, two things happen here. Circulatory volume is reduced, and the oxygen carrying capacity of the blood, hemoglobin, is reduced. So oxygen supply is reduced in these children and ultimately leads to cellular hypoxia. I go back to the initial definition of shock. I said, it's the clinical manifestation of cellular hypoxia that occurs as a result of insufficient circulation or inefficient tissue perfusion. Now you can see from hypovolemic shock and from hypovolemic shock from fluid losses and hemorrhage that ultimately the children get into shock. What is characteristic about these children from the cardiovascular point of view? Preload is reduced, whether it is from fluid losses or from hemorrhage. Cardiac contractility is increased because sympathetic compensatory mechanisms try to come in, and the inotropic effect tries to increase the contractility of the heart to compensate for the reduced cardiac output by increasing stroke volume. Now we look at distributive shock. This is a little bigger than hypovolemic shock, which we discussed. The problem with distributive shock is the venous capacitance. The venous capacitance is markedly increased. Now the vasculature, for some reasons, becomes so relaxed and dilated to the point of inadequacy. These children very likely would have not lost, may not have lost fluid from diarrhea losses or from vomiting or even from hemorrhage. And so the circulating volume may be adequate, but the capacitance, the vasculature has dilated a lot. Now, what are the types? Septic shock. Why? Because sepsis releases vasoactive mediators that dilate the vasculature. And if we look at anaphylactic shock, in cases of envenomations, the envenomations and some antibiotics causing anaphylaxis, maybe like the penicillin family, for those who react to it. Now, also neurogenic shock in children who have head injury and spinal shock. One thing that is common is increased venous capacitance. So we see increased venous capacitance causes a decrease in preload, even though the blood volume may not primarily be less, but because venous capacitance is increased, preload is reduced. Now, to compensate, cardiac contractility increases, but it varies according to the various types of distributive shock. Now, it varies in all except neurogenic shock. For neurogenic shock, cardiac contractility remains normal. And afterload varies again in all except neurogenic shock, where afterload is reduced. We'll take them individually. We said shock from the initial stage, the compensated stage, then if not arrested, we get into the stage of decompensation. Now, when distributive shock, for example, septic shock is decompensated, how does it manifest? There are two types, the warm type, the cold type. What is common among both of them is hypotension. Hypotension is common because, of course, cardiac output is reduced and blood pressure, cardiac output is a component of the blood pressure. So blood pressure is reduced, but the difference between systolic blood pressure and diastolic blood pressure is quite wide in the warm type of shock. That's why we have a wide pulse pressure hypotension for the warm type. And it's narrow pulse pressure hypotension in the cold type. Now, going by their names, extremities will still be warm, may still be warm at the initial stage, and erythematous peripheral skin for those who are light skin and maybe more common among the Caucasians. But the pulses are bounding. At this stage, it shouldn't be confusing. The child does not have normal pulse pressure at all. It is bounding pulses. The child does not have normal pulse volume, sorry. It is bounding at this point. This is different from the cold type, which extremities are cold, pale, and vasoconstrictive skin. This is important in the stages of our management and how severe we meet them. Now, we've talked about septic shock. What then is the definition of septic shock? Well, the world has gone slightly ahead of the primary definition of sepsis being systemic inflammatory response syndrome with evidence of proven or suspected sepsis. So what is sepsis? Currently, sepsis is a life-threatening condition caused by a dysregulated host response to infection, resulting in organ dysfunction. Now, there is dysfunction of the main organs resulting from an infection because the host response is dysregulated. Now, what are the components of septic shock? Circulatory abnormalities, cellular abnormalities, metabolic abnormalities in these children who have shock. Now, they present with hypotension that is refractory to fluid therapy, and they require vasopressor in order to attain tissue perfusion because perfusion is reduced in these patients. This is the definition of septic shock. Now, because we said there are organ dysfunctions, we just want to look at the various components of the new definition of septic shock. We said circulatory, we said cellular, we said metabolic. For circulatory, let's take it the first one. Despite the administration of isotonic intravenous fluid boluses of greater than or equal to 40 mL per kg within the first hour, if you find that the children are hypotensive, that is the American Heart Association classification of the 5th centile for age, and the blood pressure is below that, or there is need for vasoactive drug to maintain the mean arterial pressure of greater than or equal to 65 millimeters of mercury, there is a circulatory abnormality in that child. Again, the components of definition of septic shock: circulatory abnormalities, cellular abnormalities, metabolic abnormalities. Now, let's go to the other ones, cellular and metabolic. Now, any two of the following will qualify: unexplained metabolic acidosis, when the base deficit is more than 5 milli equivalents per liter metabolic; increased arterial lactic acid level, more than twice the upper limit of normal. This is because we said aerobic glycolysis is shifted to anaerobic and lactic acid accumulates. Organ dysfunction, again, oliguria, because urine output becomes less than 0.5 mils per kg in 1 hour. There's prolonged capillary refill time, and then core temperature to peripheral temperature gap is greater than 3 degrees centigrade. Now, any of these two, in addition to this above discussed circulatory abnormality, qualifies for septic shock. Okay, let's look at cardiogenic shock. For cardiogenic shock, it's going to come in practice. It's going to come once in a while. Maybe not as common as septic shock, but it's important to know it. Now, the problem with cardiogenic shock is inherent inadequate cardiac contractility. There is a problem with the inotropic activities. The cardiac contractility here is depressed by some problems. Now, what are the causes? Well, it's good to state before we go to the causes that many other causes of shock will ultimately end in cardiogenic shock. But commonly, cardiomyopathies like asphyxia cardiomyopathies or infectious causes like diphtheria cardiomyopathies will ultimately present with inadequate contractility, and the heart is therefore unable to meet its oxygen requirements, circulatory requirements, substrate requirements. Carditis, in children with viral myocarditis, contractility is also impaired. Now, well, if we look at the causes, we could say acquired heart diseases, congenital heart diseases, that is structural, or electrical problems. So in dysrhythmias, when supraventricular tachycardias are unrecognized, or children with complete heart block, or even ventricular fibrillation, could have problem with cardiac contractility and end with cardiogenic shock. It's worth to mention that congenital heart diseases that are duct dependent for systemic circulation, like those with left ventricular outflow tract obstruction, name it hypoplastic left heart syndrome, hypertrophic cardiomyopathy. The problem is with the left ventricular outflow tract. You know, on echo, you find the systolic anterior motion of the anterior leaflet of the mitral valve, occluding flow out of the ventricles. Now, outflow is reduced. Coarctation of aorta, critical aortic stenosis. Children with large left to right shunts also, like ventricular septal defect, patent ductus arteriosus, or large endocardial cushion defect, untreated, unrepaired over time, would also decompensate, coming with cardiogenic shock. What are the clinical features of cardiogenic shock? The problem is that the heart is unable to pump. The heart is unable to contract enough. What happens? There's back pull of blood. So you realize that these children present with significantly increased work of breathing. So in the emergency room, I find a child whose capillary refill time is, let's say, 5 seconds, that's bad. Whose Glasgow Coma score maybe is 10, that's bad. Who is oliguric? Now, is that child having hypovolemic shock, or is that child having cardiogenic shock? The child with hypovolemic shock will very likely not have a significant much increase in the work of breathing, except at the point of resuscitation, the child suffers fluid overload. But the problem with cardiogenic shock, they would have increased work of breathing, evidenced by grunting, flaring of alar nasa, use of accessory thoracic muscles. They would also have signs of pulmonary congestion, so there will be crepitation in the lung fields. And for children, maybe not excluding the infant, children below 1 year, because of the shortness of their neck veins are engorged in these children. In older children, it can be seen that jugular veins are distended. Other features of cardiogenic shock is shared with other types of shock, like weak pulses, the tachypnic, slow capillary free time, and others which are general. It is worth noting, however, that there are various clinical subphenotypes of cardiogenic shock: the wet type, the dry type, the warm type, and the cold type. Because there is backflow owing to inability of the heart to contract, pulmonary capillary wedge pressure is increased here. So there could seem hypovolemic, even though the amount of blood is not lost by any point, but circulation is reduced. So pulmonary congestion occurs in these children, and they are the ones that will have respiratory distress. The backflow will cause hepatomegaly, but mind you, the Gibson's capsule in younger children is still very elastic. So the liver is going to enlarge significantly. And we may not find peripheral edema, but for older children, there may be peripheral edema. Now, the dry type, well, having low to normal preload, poor skin and end organ perfusion, this is a perfusion problem for the organs. Now, the warm type, there's near normal. These ones will not need fluid in resuscitation. Of course, the cold type are the ones with cold, clammy extremities. Something has to be done. What of obstructive shock? So we've discussed hypovolemic shock, discussed the distributive shock, we've discussed cardiogenic shock. Now we're talking of obstructive shock. In this condition, cardiac contractility, unlike cardiogenic shock, is normal, but there is impairment in the ability to pump. There's an obstruction somewhere. We could find it in cardiac tamponade. Children, again, with left heart obstructive lesions, like we said. Children with tension pneumothorax and pulmonary embolism. Let's look a little at cardiac tamponade. For children with cardiac tamponade, there is rapid excessive accumulation of fluid in the pericardial space between the visceral pleura and the parietal pleura. Now, normally, we could find little amounts of fluid in the pericardial space. But if there is rapid, massive accumulation of fluid in the pericardial space, there is an obstruction with ventricular filling. You'll find on echocardiography that the heart is dangling anteroposteriorly, mediolaterally. Instead of the heart that should normally be contracting, the heart is just shivering, and there is circumferential accumulation of fluid in these children. How do you get to know? Classically, the child is in cardiac tamponade. The classic triad of Beck, which we call Beck's triad: distant heart sound, dilated neck veins, and a decreased blood pressure, is classic of cardiac tamponade. This is dramatic, and the child has to be relieved from it as fast as possible. Well, I've talked about left heart obstructive lesions. Similarly, tension pneumothorax will need to be, there's problem compressing the thorax, the lungs, ultimately the heart gets into shock. And pulmonary embolism, this needs to be removed from the tract. Now, let's quickly look at the management of the various types of shock. The 4 types of shock and the 3 types of distributive shock. What is general about our approach? Regardless of the type of shock we have, the clinician is supposed to recognize primarily that the child is in shock. I will repeat, recognition is by looking at the 3 organ systems we talked about. Cardiovascular system, where we have increased capillary refill time, pulse pressure, pulse volume abnormalities, heart rate abnormalities. The central nervous system, where there is altered sensorium, Glasgow Coma score is reduced, and the genitourinary system, where the child has reduced urinary output. These have to be recognized as fast as possible. When recognized, then resuscitate. And then we'll discuss post-resuscitation care when they are stabilized. Well, because we commonly talk of workup, we will just say this, but I would like to emphasize that we will not waste time collecting samples in a child that is that we have to do it anyway. So workup is done at or after initial stabilization. There are some investigations that must be done for good management of shock, or they are based on the types of shock. So full blood count, grouping and cross-matching blood culture necessary for septic shock, blood gas analysis for all types of shock, serum lactic acid, for all types, we want to get to know the severity of shock. However, this list is inexhaustive because there are various types of shock, and we'll talk about it as we go along. So let's start with the management of distributive shock. And starting with septic shock management, first of all. Now, three things that are considered in the management of septic shock: hemodynamic management, corticosteroid therapy, and then adjunctive therapies that we'll look at. Now, for hemodynamics, the Surviving Sepsis Campaign guidelines have brought the 1 hour bundle, which recommends the commencement of intravenous fluids. All these are mentioned in must be commenced within the first hour at getting to meet the patient. So treatment with crystalloids, measurement of serum lactic acid concentration because it's a marker of illness severity, administration of vasopressors, because like we said in septic shock, there's failure of maintaining adequate blood pressure. There's hypotension despite going more than 40 mils per kg of crystalloid. So vasopressors become important, and we'll talk a little about the types of vasopressors. We must obtain blood culture and administer broad spectrum antibiotics. All these within the first hour of presentation. We will look at this algorithm for the management of septic shock. Now, looking at this algorithm shouldn't be too confusing. The boxes you find in pink are things you must do immediately, whereas the ones in blue are things you do ongoing, the management. That is why we said workup could be ongoing while we manage the children in shock. So first of all, we recognize that there is infection, there is dysregulated response to infection, and we recognize that there's organ dysfunction. So we screen for sepsis, and now we assess the various organs for the signs of sepsis. Cardiovascular system, we look at the heart rate, blood pressure, look at oxygen saturation, look at pulse rate. Mental status is going to be less. It's going to be altered, Glasgow Coma score below 15. While if this meets the criteria for septic shock, we move straight into resuscitation. As we do that, the child is supposed to be connected to cardiovascular monitor, where we take care of all these parameters. Child should be catheterized for us to measure urine output. Temperature has to be taken. Serum lactic acid levels have to be taken. So we go to resuscitation because we have recognized that this child meets the definition of shock. With hemodynamic instability, we want to swing into action. We obtain blood cultures for all patients as fast as possible, administer broad spectrum antibiotics. Now, hemodynamic care, administration of intravenous crystalloids, normal saline or buffered salt solution. The next slide is going to talk about controversies. So let's keep our minds warming up for controversies. Now, for this algorithm, we say up to 30 mils per kg of crystalloid over 3 hours. This is debated. Now, if this fails because there could be permeation of fluid into the intravascular space, albumin could be recommended if there's failure of response to the crystalloid. We must monitor central mean arterial pressure. When crystalloid resuscitation fails, we commence vasopressors. We will discuss vasopressors, but it's here for you to just see in the slide. Now, when fluid crystalloid fails, vasopressors fail, and shock persists, then it's time to administer steroids. Again, there is a slide on that. But supportive treatments, the child, because sepsis can result to multiple organ dysfunction. So if it's an acute respiratory distress syndrome the child is getting to, child should be intubated and ventilated. Now, renal replacement therapy becomes important in those who suffer acute kidney injury from fluid accumulation. Now, back to our definition of shock. there is insufficient circulation and inefficient perfusion. So if circulation is a problem, then removal of waste products of metabolism will be a problem. So it accumulates and needs to be removed by renal replacement therapy, dialysis. These children will need enteral feeding. Glucose monitoring has to go on. We said ongoing monitoring, and then checking for venous thromboembolism prophylaxis. Most children in our environment may have borderline anemia, and so there will be need for transfusion, but we'll still look at all that. Now, the controversies around fluids. We have two big guidelines that anybody treating shock will come across. So the Surviving Sepsis Campaign guidelines and the early goal-oriented therapy. Now, the Surviving Sepsis Campaign bundle recommends that 30 mils of crystalloids is given in 30 mils per kilogram body weight is given in 3 hours. This bundle is currently under review. There is improved outcome observed in children with septic shock when goal-oriented therapy, where the children receive at least 60 mils of those who received less fluids. Now, looking at the fluid, just a little bit more on our controversies. We look at this from Journal of American Medical Association, classifying non-survivors and survivors based on the amount of fluid crystalloid received within the first hour. We realize that those who received less than 20 mils per kg had more non-survivors. We do not want this. Those between 20 and 40 mils per kilogram, again, more non-survivors. But survivor was higher among those who received more than 40 mils per kilogram body weight within the first hour. So authorities' guidelines vary, but this seemed to favor more of bias in pediatrics as what to do. Now, mind you, we said most children in our environment would have borderline anemia. So fluid-induced hemodilution compromises oxygen delivery in anemic children. So what do? After initial boluses, we'll be quick to transfuse with packed cells as opposed to multiple fluid boluses. Now, the packed cells have hemoglobin, so there'll be oxygen delivery, and it has its own volume. So volume is taken care of in these children. So we said in hemodynamics, we look at fluid therapy, we look at vasopressor therapy. Now, when hypotension remains unresponsive, despite initial fluid resuscitation, we want to maintain a mean arterial pressure of greater than or equal to 60 millimeters of mercury. By the way, mean arterial pressure is 1/3 of pulse pressure plus diastolic blood pressure. We want to maintain it above, and it tells about perfusion anyway. It's better indicator of perfusion. We want to maintain, so vasopressor therapy. If it is warm shock, conventionally we give norepinephrine. And if it is cold shock, conventionally we give epinephrine. Therefore, our decompensatory categorization of shock, which we discussed earlier, becomes important because when fluid fails, getting to vasopressor therapy is now based on a decompensatory categorization of that child becomes important. Although some authorities, so there are some controversies around steroids, but this is where we stand. The Surviving Sepsis Campaign bundle recommends, as we've said earlier, the use of steroids only if hemodynamic instability persists after adequate fluid resuscitation, like we said, 60 mils per kg in the first 1 hour, or after vasopressor therapy. Why do we use corticosteroids? Because they act by immunomodulation and cardiovascular modulation. There are some meta-analyses that strengthen the use, that support the use, like the Australian-based adrenal trial, where a lot of subjects were recruited, and it's a recent trial. And the Approaches trial also, both in 2018, just 2 years ago, showed that low-dose steroids, use of low-dose steroids, is associated with more rapid resolution of septic shock and shorter stay in the intensive care unit. So after fluid therapy using crystalloids and vasopressor agents, steroids must be close by. Now, yet there are other therapies, which we call the adjunctive therapies. Expanding on the immunomodulatory effect of steroids, some other anti-inflammatory and immune modulation strategies are currently being studied. But however, these are not yet licensed, but these are things that will come our way at various levels of clinical trials. Now, it's center that would see a child with shock should be close by to do renal replacement therapy for cytokine removal. We said that the child could have shock. It could be pre-renal shock, pre-renal, or intrinsic renal because of sepsis. Pre-renal from hypovolemic, intrinsic renal from septic shock. There will be accumulation of uremia, uremic metabolic products, fluid overload, and hyperkalemia. There is need to do renal replacement therapy. And when respiratory organs are failing, they need to support respiration, because at this point, the child will have been going beyond decompensation into refractory stage. You want to support by mechanical ventilation. At the point you are starting mechanical ventilation, you are considering extracorporeal membrane oxygenation. Well, when we have all this approach to the management of shock, where are we looking at? We've defined shock. We know what we are treating, but what do we see? What are our therapeutic goals? Now, the Surviving Sepsis campaign gives us about 6 of them. But simple, if we just invert our recognition, the points that make us identify shock, we could easily get this. Mental status should return to normal, Glasgow Coma score of 15. Blood pressure should return to normal, heart rate, and other aspects of cardiovascular organ dysfunction that we have earlier talked about. Urine output should return to normal again. We said in shock, it's up to less than 0.5 mils per kg per hour. Now, other supportive care should include normalization of serum glucose level and other metabolites. And lactic acid levels should have decreased down to normal, because increase shows severity of septic shock as we're treating here. Now, other types of shock, other types of distributive shock, we said septic shock, anaphylactic shock, and neurogenic shock. For anaphylaxis, we want to treat with intramuscular epinephrine as fast as possible. And if we need to repeat, we'll go intravenous route. I should have said this earlier. A venous access becomes very important within the first 3 minutes of seeing a child in shock. So if the peripheral venous access is difficult, every clinician managing children must be quick to get the intraosseous route. How do you get intraosseous access? Just the tip of your finger at the tibia tuberosity, about 2 centimeters below and medially, you get the smooth surface of the tibia. So you go just 2 centimeters below the tibia tuberosity. At that point, we go in with some force until we feel a give, you stop, you are in the space already. So you can use it as for fluid, for resuscitation. In anaphylactic shock, just like septic shock, there is increased venous capacitance. But the problem here is because of leakages from the fluid. So you want to use leakages from the vessels. You want to use crystalloids judiciously. So you do not want to overload the circulation. Antihistamines and corticosteroids could be used to blunt capillary leakages, because this could cause pulmonary edema. Because the anaphylactic reaction, maybe say from envenomation, causing circulatory collapse in shock, can as well cause issues in the lungs, bronchoconstriction. Some of them may require nebulization. But if after all this, there is need for continuous infusion of epinephrine, then there will be need for intensive unit care. Now, the third type of distributive shock is the neurogenic shock. Now, this is a type of shock where you find every other factor that meets up with our three systemic classifications: cardiovascular system, the urogenital system, and the central nervous system. However, in this condition, there is bradycardia, not tachycardia. There's bradycardia. So a child with shock and there is bradycardia, just understand we have neurogenic shock. Now, usually from head injuries, from spinal injuries, usually initial fluid boluses is usual for shock, but they will require vasopressors because there's increased venous capacitance. You would want to have an urgent neurological evaluation, the neurosurgical team to work out a treatment plan. Spinal injuries, head injuries could have neurogenic shock. Hypovolemic shock is what we commonly meet in our emergency rooms. Like I said earlier, it could be due to fluid losses from the gastrointestinal system, gastrointestinal tract, or from blood loss. Now, for whatever, we will need to replace the fluid quickly with 20 ml per kg of crystalloids, given as bolus over 10 to 15 minutes. We repeated as much as needed. Now, let's bear in mind that albumin is good for additional intravenous volume for shock as plasma expander. But we understand that crystalloids are more handy and they are valuable. Now, if boluses do not improve signs of hypovolemic shock, like it will not do in septic shock. So when hypovolemia, when hypotension is not corrected, despite use of crystalloids, we check two things. Are we dealing with septic shock? And so you are now thinking of vasopressors. Or are we dealing with shock from hemorrhage? So we have to reevaluate to know if there is blood loss into the gastrointestinal tract. And in that condition, we will need to urgently transfuse packed cells. This will help both in circulation and oxygen delivery. Now, to cardiogenic shock management, we said the problem in cardiogenic shock is intrinsic defects in cardiac contractility. So we want to treat with inotropes to increase cardiac contractility, and we want the heart to contract against a reduced load in front of the heart. That is, we want to reduce the afterload, so we give vasodilators. The place of fluids in cardiogenic shock must be used, if at all, judiciously, and most likely the dry type when we consider the clinical subphenotypes of cardiogenic shock. For infants with duct-dependent lesions, where the patent ductus arteriosus is getting to close, we will need infusion of prostaglandin E1 to maintain its patent. Now, for obstructive shock, like we find in cardiac tamponade, tension pneumothorax, in pulmonary embolism, the temporizing measure, of course, there's something that even a junior doctor can do, and that is initial isotonic crystalloid resuscitation. However, definitive measures, we must remove what is impinging on the heart, impinging on the lung, impinging the pulmonary circulation. So for cardiac tamponade, you have to quickly do a pericardiocentesis. So how is it done? With the child in supine position, of course, we head propped up with all the support. These children will be distressed. We said, how do you know cardiac tamponade? The classic triad of Beck: distant heart sound, dilated neck veins, and decreased blood pressure. You want to relieve this, it's a dangerous sign. So with the child in supine position, two routes, either a subxiphoid approach or the apical approach. Although I will discuss more of the subxiphoid, that area is infiltrated with xylocaine to at least take care of local anesthesia. Then the needle is introduced under echocardiographic guidance. Some people could do it blindly, but under echo guidance, or the needle connected to an ECG strip So you quickly know if the myocardium is touched. So with a bevel facing the tip of the left shoulder, one penetrates through the subxiphoid approach at an angle just between the medial surface of the cartilages and the xiphoid process. So we go in, there will be resistance. And until we just feel a little give, we stop, realize our fluid comes out. So what kind of fluid? It could be pus, pyopericardium, it could be serous, it could be blood, hemopericardium, it could be air.
Sorry for the brief break. Dr. Peter is coming back on. I don't know what happened. Dr. Peter, please share your screen again. You went off briefly. And please increase your volume. Please increase your volume and share your screen again. You went off momentarily.
Okay, let me get it.
Yes.
Okay, sorry for the network, the error, the delay.
You don't forget.
Hello?
Facebook. Go ahead,
Hello?
go ahead. You go ahead. We're hearing you loud and clear. You can continue.
All right, thank you. Okay, so we drain the fluid. We get in and feel a give. The fluid is drained, pericardial fluid. That is pericardiocentesis. Now, the fluid, the trocar is connected to a two pericardiostomy tube. Now, we would want to drain cardiac tamponades carefully because we do not want to convert the child from tamponade to pericardial decompression syndrome if it is drained too quickly. So we drain slowly over a long time. So similarly, just like cardiac tamponade is drained, we also want to drain the tension pneumothorax with needle decompression. And for pulmonary embolism, fibrinolytics and anticoagulation become
I think we're having some problems again. Dr. Peter. Dr. Kefas. Don't know what's happening with Dr. Peter's internet connection. Sorry, we'll soon come back on. Something is, I mean, this is this is Nigeria. It happens from time to time. Having some internet issues. I can see questions are already coming up on the chat. Try and put the question on the Q&A as much as possible so that we don't forget any question, and so that those that watch afterwards can still benefit. Dr. Peter, can you go ahead, please?
Okay, thank you. So after resuscitation in the management of shock, sorry for the network issues. After resuscitation, recognition of shock, resuscitation, then we talk about post-resuscitation care. So we now sit down and take a detailed history, careful head-to-toe examination, because we've talked of a lot of types of shock. And so let's see, assuming it's a child with septic shock, we want to take the history to determine the cause of the sepsis. Careful head-to-toe examination, you may realize a blanching rash on the trunk. And of course, you think quickly, in a child with sepsis and that rash, you're thinking of meningococcemia. Now you re-evaluate after each step as it is done, arrange for appropriate consultation, and the child is admitted to critical care unit for ongoing care stabilization. This, if done, would have given some good care to our children. Now, I'll conclude by saying that management of pediatric shock, which is a leading cause of infant and childhood mortality, is largely possible if it's recognized early and if there is clear understanding of the therapeutic measures. Thank you.
Okay, thank you very much, Dr. Peter. That was quite deep and insightful. So we'll be taking questions. If you have a question, just click raise your hand. Just click raise your hand or write in the Q&A tab so that questions can be answered. Okay. Okay, so I have some questions here already written down. If you have a question, just raise your hand as well, and I'll also just unmute you, and you can go ahead and talk. So I'll read some of the questions, Dr. Peter. Any of the panelists, to Dr. Subero and Dr. Kefas, you can answer any of them. Um, one says, in clinical settings, if a patient finds a child with features suggestive of shock, and he is unable to specifically recognize the type of shock, what should the person do? How should the person approach management? Dr. Peter or Dr.
Okay, in clinical setting, okay. So in clinical setting, sorry, I would have wanted to see yeah, if a physician finds a child with features suggestive of shock, but he's unable to specifically recognize the type of shock, what should be the appropriate approach to management? Well, recognition of the type of shock, that is why we spent a long time talking about the various types. It is important, but well, hemodynamic care becomes very important. At least the problem, one underlying problem in shock is failure of circulation. Start IV crystalloids and call for a senior to help and assess, because looking at the various types of shock, which you could actually pin the exact type, you need to know whether you are dealing with a cardiogenic, dealing with hypovolemic, and if it's hypovolemic, is it because of hemorrhage, is it because of diarrhea losses? So it becomes really important to know what exactly causes the shock. It is good the physician has been able to recognize that this child is in shock. So the physician is supposed to know the specific type, start hydration, call for help.
Great, I think that's a good answer. Someone said, well done, presenter. Which vasopressor is preferable in septic or distributive shock? Dobutamine or dopamine? Maybe, okay, Dr. Peter, go ahead. Or you wanted Dr. Zubero or Dr. Kefas to help you? The question is from Dr. Oyewusi from Ilwa. It says, what is the, which one is better? Is it Dr. Oyewusi? No, Dr. Alabi. He says, okay, which vasopressor is preferable in septic shock?
The slide in front, hello?
Yes, go ahead.
Hello?
Go ahead.
Okay, the slide directly being projected. Okay, currently, looking at vasopressors in shock, yes, dopamine, dobutamine, they're all those types. Now, we looked at the decompensatory categorization of septic shock, and we said it could be cold shock, warm shock. In both cold and warm, there is hypotension, but in the warm type, there is wide pulse pressure hypotension. The child will benefit from norepinephrine. For the cold type, epinephrine. The place of dopamine, or better still dobutamine, it's a little critical. The child needs to be normotensive. The child needs to be normotensive. So you use this to get the child out of hypotension and maintain it with dopamine. Now, dopamine, based on the dosages you use, there is the renal dose from values 1 microgram per kg to about 5 microgram per kg per minute. You use it for renal perfusion. Now, it depends on what you really want to achieve. For cardiac contractility, between 5 to about 10 microgram per kg per minute. And if you go above that, you are looking at vascular effects. But for one to use dopamine, dobutamine, it has its place, but commonly I used the point of vasopressor therapy when crystalloids have failed. So crystalloids have failed, the child is still hypotensive. In hypotension, you will not use dopamine. That is why I stated it. So if we have measured the mean arterial pressure and it is now greater than or equal to 60 millimeters of mercury and above, and you want to sustain, use dopamine.
Okay. Dr. Yewusi from, I think I see the same answer. We talked about what is the place of inotropes or dopamine and dopamine management of shock. I think that has already been answered. Say, can there be AV block from shock? Dr. Suberu or Dr. Kefas, you can also add at any time you feel you want to add anything. Can there be AV block from shock?
Hello.
Yes, go ahead.
Yeah.
Okay, just as a add-on concerning the question with regards use of dopamine or dobutamine in septic shock. Well, if you are left with the option of just choosing between dopamine and dobutamine, dopamine will be preferable to dobutamine in septic shock. And this is because dopamine causes peripheral vasoconstriction. And then we know in septic shock, already you have increased venous capacitance. There's already vasodilatation, and dopamine will help in that regard. Unlike dobutamine, which causes peripheral vasodilatation. So you don't want to use dobutamine in septic shock because it might worsen the peripheral venous congestion.
Okay, thank you very much. Say, can there be AV block from shock?
Okay, so rather, complete AV block will cause cardiogenic shock. So it's here on this slide. Complete heart block can cause cardiogenic shock. However, I understand the question. Can there be AV block from shock? And I said when I was discussing this slide that other forms of shock have a common final pathway of cardiogenic shock. So commonly, the AV block will rather cause a cardiogenic shock, but other forms of shock will cause the final common pathway. So I would rather say AV block will cause cardiogenic shock.
Okay. What is the role of oxygen? Dr. Osaji, a physician. So what's the role of oxygen while co-administration of bolus or crystalloid?
Okay, so supportive therapy for shock. Supportive therapy, if we look at this slide, monitor hemodynamic and organ function. And one of the organs is the lungs, the respiratory system. And go to the next one, other supportive therapies, mechanical ventilation. Now, we want adequate perfusion. We want adequate oxygen delivery, because we said shock is the clinical manifestation of cellular hypoxia. Oxygen is important. Oxygen is very, very important. And in fact, when oxygen delivery is so, and that's why this slide shows us arterial oxygen saturation monitoring. So you monitor heart rate, blood pressure, arterial oxygen. It is important. So oxygen is necessary at this point as part of the management plan. And that's why, in fact, if it fails so badly, there is a place for mechanical ventilation. So as we go on giving crystalloids, oxygen become necessary. Intranasal.
Oh, okay, Dr. Lawal, I'm going to allow you to talk. Please ask your question. Dr. Onalapo Lawal. Dr. Lawal Onalapo, can you go ahead with your question?
Yes, sir. Hello, sir.
Yeah, go ahead.
I already asked in the question and answer, sir, that is it true intravenous antibiotics that are bactericidal can worsen septic shock through the release of endotoxins after killing the especially gram-negative bacteria. Because I read a particular time in Bedo and Jaja that it's usually better to give bacteriostatic antibiotics rather than bactericidal antibiotics. That bactericidal antibiotics, especially when they act on gram-negative bacteria, they end up releasing some endotoxins after they kill the bacteria, and it probably worsen the septic shock. So I actually joined the forum late, so I don't know whether you spoke about that. So I just wanted to know, sir.
Okay,
Yes, sir.
go ahead. Dr. Peter, Dr. Subir, Dr. Kefas.
Okay.
His question is it true that bactericidal antibiotics worsen septic shock because of the release of endotoxins when the bacteria dies?
Okay, so the problem in septic shock is there are multiple problems in septic shock. Primarily, the bacteria releases vasoactive substances to increase the venous capacitance. You have to get rid of the bacteria, so antibiotics based on local guidelines for empiric therapy is standard of care. Mind you, you would have been giving fluid to increase perfusion and for the kidney to excrete whatever metabolic products or those toxins that would have accumulated. I will go ahead and give antibiotics based on empiric local guidelines. Hydrate, the kidney would excrete it. And if that fails, renal replacement therapy as indicated on this slide.
Okay, so go ahead with your antibiotics as usual. So far, you are doing everything, Dr. Peter.
Yes, yes.
Go ahead with antibiotics as usual. You cannot say you want to give bacteriostatic when you have a very terrible shock. Use your existing ones. Yes, it's true that some level of endotoxins may be released when the bacteria dies, but it's not an indication for not giving the appropriate antibiotics. Still, when you perfuse the person properly, you do all the other things, it will take care of it at the same time. So I think that should not be an indication. Yes, you are correct in theory, but in practice, you put all of them together while treating. Okay. Somebody, I don't know if it's a question or it's a contribution. You see the role of early use of ECMO in some shock to prevent entry into refractory stage while searching for solution. 2, differentiating between, okay, question likely. What's the role of early use of ECMO in preventing shock from entering into refractory stage? And then number 2, how do you, differentiating between neurogenic shock and refractory or end stage of other shock, since the end stage is all the same? The patient has presented late, how to differentiate which one is which after all of them are looking alike? And then what is the dose of dobutamine and dopamine? And whether it's nephrogenic or cardiogenic in the indication.
Okay. Okay, let's go. By the time we looked at the, let me go to the slide that deals with adjunctive therapies. I think with the slide projected, it should help clarify a few more things. Adjunctive therapies in the management, good. So the role of extracorporeal membrane oxygenation in some shocks to prevent entering into the refractory stage while searching for solution. Good if it's available, but you see, commonly, when we do the basic things about hemodynamics, which is of utmost importance, maintaining circulation, and if crystalloids fail, these are guidelines that have steps. These are guidelines, so the surviving sepsis campaign guidelines and the early goal-directed therapy guidelines. Now, after crystalloids, vasoactive substances, steroids, Now, other therapies are what we have stated. Because with shock progressing beyond the compensated stage, other organs become affected. And that's why we talked about renal replacement therapy for the renal complications. When you're talking of extracorporeal membrane oxygenation, we'll go talk about it relating to oxygenation. And that was why one of the questions by Dr. Saji talked about the role of oxygen. Oxygen is used. If we realize that the respiratory system is failing, we go to use of mechanical ventilation. And if it's getting refractory, we consider extracorporeal membrane oxygenation. So now I will not use steroid first because steroid is important. I would use, and so I will not use ECMO first. We'll give them their rightful place. That is, you're talking about multiple organ dysfunction now, failure of the respiratory system. If the child is having good circulation, and we've done the other hemodynamic management, and there is no multiple organ, the cardiovascular system has failed in shock. We do not want the respiratory system to fail. And if it does, we talk about mechanical ventilation, then we go to extracorporeal membrane oxygenation. So ECMO comes in terminally, and so we will not revert the order. That's how I see it. Then differentiating between neurogenic shock and refractory or end stage of other shock, since end stage is the same. Okay, for neurogenic shock is a type of distributive shock. In neurogenic shock, there's increased capacitance of the vasculature. I said that in this shock, there is history of head injury or spinal injury, and also differentiated from by having bradycardia. So the bradycardia component is important to differentiate between neurogenic shock. So you find children that satisfy all the criteria for shock, but with bradycardia. I'll ask, is there a history of spinal injury, head injury? Then I'll be confident it is neurogenic shock, and we'll get further neurologic evaluation. By the time we are getting into refractory shock, because the various stages of shock, the initial phase, the compensated phase, the decompensated phase. In the compensation, the cardiovascular system has failed. There's hypotension not responding. By the time it's getting refractory, multiple organs have failed. So that is for refractory or end stage of other shocks. The final common pathway will be cardiogenic. The heart is going to fail. So to differentiate, I would say the neurogenic shock at terminal stage will look like the other forms at refractory stage anyway. But the earlier stage of neurogenic shock stands out with its own bradycardia. So that's for neurogenic shock. Now, I think hospitals and institutions will have standard operating procedures with guidelines and dosages. However, let me talk about the dosages of dopamine. Like I said earlier, moving from 1 to 5 microgram per kg per minute, you are just interested basically in renal perfusion. So you step up the dose for, because you said, and in nephrogenic and cardiogenic indication. So if I'm using dopamine for cardiogenic shock, I am using between 5 to 10 microgram per kg per minute, because that is to increase inotropic property of dopamine. Above that, I am trying to achieve the vasoconstrictive effect, like was said by one of the panelists, because in distributive shock, the problem is dilatation of the vessels. So you want, but this can easily be gotten from guidelines, and it's always better to refer to them.
Okay. Any other panelist has anything to say? So I'll just add that I think the doses are the same with adults. So 1 to 3 renal dose, you increase perfusion generally, but you also increase renal blood flow and will help urine output. Greater than 5 to 7 or 5 to 10, you're typically doing, you're probably going to be increasing little of renal, and then you're going to be more of cardiac. Thereafter, between 10 to 15, you are going to be causing some renal vasoconstriction, not vasodilatation anymore. At this point in time, you are probably getting for pressure support, in which case you are helping the blood pressure more vascular than cardiac. Or by the time you are getting to those kind of high doses, continuous, is probably be a nice time to switch to dobutamine. So the dose again is per milligrams per kg. Now the vial comes as a 200 milligrams vial. So you need to take time and calculate how many milligrams per kg are you going to put in your syringe pump or in your drip giving set, calculate the weight of the child and how it will go over time so that you achieve your milligrams per kg per minute, 1 to 3 milligrams per kg per minute. So that will give you a renal dose. Then a little bit higher will give you your cardiac dose, and higher will give you your pressor dose. So typically less than 5 renal, less than 10 cardiac, 15, 20, you're getting to pressor dose. But at that point in time, you are beginning to cause vasoconstriction rather than dilatation. So when you get to those kind of high doses, and the patient is getting such high doses to maintain circulation or to maintain, you probably may need to, at that point in time, be switching to dobutamine. If, however, you thought it may be, and I'm talking generally now, I think it's the same thing in pediatrics. If, however, you think that this may be primarily cardiac, then dobutamine may be and there is no renal component or distributive component, then dobutamine may be more targeted and might not go out have all that excessive vascular effect of moving, changing from peripheral to splanchnic circulation. That's something you should consider also going forward. Okay, so I think we've answered the two or three questions, giving doses of which is better. We've answered about ECMO. ECMO is hardly available in this country. Maybe 1 or 2 centers have. Limited hospital, Limi cardio care will likely soon get an ECMO machine, but that we're planning in the next 12 months. But it's typically not there. Dr. Asala has a question. Dr. Tosin Asala, I will allow her to speak, or him, I'm not sure. Dr. Asala Tosin, you can go ahead with your question. Your hands are raised. Dr. Tosin Asala, you can go ahead with your question. Unmute yourself and talk. Dr. Tosin Asala. Okay, well. Okay, so thank you for the detailed discussion. What is your take on post-operative neonates who are in septic shock? How will you make the diagnosis, noting their usual unstable vital signs? And what is your usual protocol of management? Post-operative neonates in septic shock, how will you make the diagnosis because vital signs are difficult to use according to the person? And what is your usual protocol of management?
Okay, thank you, Dr. Arwa. That's a pediatric surgeon from the University of Ife. He's a friend of mine. Thanks for hooking up. We still go back to the basic definitions of shock. So what is your take on post-operative neonates who are in shock? We still look at the various signs, and that is why that neonate, okay, this was general for children, but we still look at the cardiovascular system. I would still, in a neonate, be able to tell if the capillary refill time is slow. It's clear. Blanching on the nipple will tell me that. Neonates should be placed on monitor. So in our institution, we have the monitor. So our babies in neonatal intensive care units are placed on monitors. So you can actually tell from the pulse reading, from the pulse, look at rates. Just look at rates alone. You can tell from your pulse rate, from your blood pressure monitoring. So you're actually looking at the basic definition. So pediatrics for neonates or older children. So you look at them, these children are sure. So how will you make the diagnosis? Noting the usual unstable vital signs. and what is your usual protocol of management? Protocol of management again. So identification of shock is identification of shock. That this child is septic. So septic shock primarily, there is sepsis, there is organ dysfunction, there is increased capacitance, and those basic definitions of shock, as we have said, will be there in the neonate. You just need to be a little bit more careful. How will you make the diagnosis? The same. Instability of their vital signs. Take, for example, we say that let's go to pulse rate. You see, pulse rate, you expect it to be, you are getting a pulse rate of above 120, 140, 160. This child is tachycardic, and tachycardia is part of it. For blood pressure, again, for the blood pressure, the American Heart Association 5th percentiles, the chart was given earlier. I don't know, maybe you joined a little bit later. So you get back to the monitor. So we have that in our center now. So the neonate's blood pressure should be at least 60 millimeters of mercury. This is easy if you have a monitor. Now, how will you make your diagnosis? Just like every other child in pediatrics, just a little more care about the neonate. And what is your usual protocol of management? Again, just like we do for all forms of septic shock, I will do that, and the algorithm given is what is stated. However, dosages would have to be a little bit more cautious. Of course, we know commonly use your infusion pump to get the circulation in place. Antibiotics, the dosages will be adjusted according to the dosage for the babies, and they'll be cared for just like that. So neonates will just need a little bit more care. But the management is essentially the same. So we see a lot of babies with neonatal sepsis. So managing a baby with neonatal sepsis, getting into shock, it's just like managing the post-operative neonate who is in septic shock. Thank you.
Okay.
Yeah.
What?
Okay.
Okay. Yes,
Okay,
go
I
ahead,
want
Dr.
to add something.
Go ahead. Go ahead.
Just by extension of the issue of monitoring the child who is in shock, by extension, even the other bigger children, actually. The issue of having monitor in the center is very important, including the one that you can monitor the blood pressure. So it's very important, and also need to be functional, and also the nurses need to monitor. Of course, we talk about the child being maybe catheterized, you have to monitor the urine output. Those are all the specific groups we talk about that you can watch, from the vital signs to the urine output, all those need to be monitored. So in some centers, apart from the children in intensive care, for some centers, actually there are some centers they call high dependency unit, HDU. Those children need to be monitored in those kind of settings, or the ICU, if you have ICU, or general monitoring of that child is very important. Then the issue of referral too, because you're dealing with people from different centers now. Okay, there may be some center that you feel they may not be able to handle the case. So the issue of referral also is very important to know at which point you need to refer the child. But of course, the issue of resuscitating the child, the first, at least to give IV fluid, to give some normal saline to resuscitate, to bring up the low blood pressure that is low, bring it up is very important. Even in a center that at least no center that won't be able to at least set line and at least give normal saline and maybe give oxygen before transferring the child, because in our setting, I discovered some centers, maybe these children will come, they won't even examine them. They'll just say, go, we can't handle it, or maybe we don't have space. And nothing will be done in the next 1 hour before they go to the next center, the child is gone. So those are some other important things I talk about. The issue of maybe doing chest x-ray and echo, the important procedure, especially when you talk about children with drug-dependent lesions. How do you do diagnosis, and so that you know what to do? So the issue of doing chest x-ray and also echo is very important. So you have all the networks, or maybe in the city you have some place where at least all those things are necessary. So you can refer the child there with, so they can have those things if you suspect those kind of lesions. Thank you.
All right, great. That's a very good contribution as well. Dr. Abdullahi Husseini, you can go ahead and mute yourself and ask your question. Yes, I can hear you.
Hello?
I can hear you.
Okay. Our first question regarding the patient with septic shock and all the other shocks But you have renal failure, you are making more than 0.7 hours, and you are taking a combination of other necessities. Is there any for this crucial because you know, most in our many of our symptoms, you don't really have this renal replacement therapy. So I don't know, is there any use of crucial you check after you have resuscitated with crystalloid and you have given maybe probably fracture in these children?
Okay, frusemide, is that what you said? Did you say frusemide?
Yes.
Okay.
In children with septic shock, after you adequate your resuscitation with crystalloid and possibly fractures and still are not making adequate to them. Then my next question, please, is in the differentiation of the
I didn't hear you again. Okay, we can't hear you again, Dr. Abdullahi. I think he has gone off. But I think we can answer that. He's asking about the use of frusemide. That is after you have resuscitated the person. What do? You have resuscitated the patient and the patient is still adequate resuscitation, the patient is still not making urine. What about the role of frusemide in such a patient? Dr. Abdullahi, are you back? You have other questions to ask? Hello? Okay, maybe we should start answering that one. Go ahead, sir.
Okay, thank you for the question. Frusemide in standard management has no role except if there's an overzealous resuscitation with crystalloid for hypovolemic shock. Now, these children should be monitored. Shock is an emergency. And so these children should be monitored, connected to monitors. So by the time one resuscitates a child with fluid in hypovolemic shock, and you start realizing the child is getting into respiratory distress, you start picking crepitations in the chest, that child is overloaded. At that point, one has done a little more harm than good. At that point, you could give low dose frusemide to just help. But for septic shock where the question is asked, the treatment plan, management plan recognize, resuscitate, and stabilize. Now, in the resuscitation, said, hello?
Right.
Okay, we said hemodynamics. We look at the hemodynamics by maintaining flow using crystalloids, using vasopressors, using steroids. By the time this is done, the problem primarily was circulatory, was perfusion. If we are able to get this child back from maybe a decompensated state to compensated, and mind you, we had therapeutic endpoints. If you are able to reverse, you will not need to go into where the kidney is not able to excrete metabolic waste. However, if there is a delay and we get into the refractory phase where there's multiple organ dysfunction, the child has gotten into acute kidney injury. And acute kidney injury from hypovolemic shock is pre-renal. Acute kidney injury from septic shock is intrinsic renal. And so at that point, you need to co-manage with a nephrologist. I still wouldn't frusemide because you would even so if it was a child that suffered intrinsic renal failure, you now give frusemide to further decrease the renal perfusion, and you worsen it by even creating more pre-renal. So you now end up with an intrinsic renal and a pre-renal failure. So for frusemide, we will just keep it aside.
Okay, I think that's very much straight. I know there's some controversy about frusemide in the management of renal failure, of acute renal failure. But generally, I think that controversy has been answered by studies. And the role essentially has been narrowed down that there is absolutely no role. It does not really affect mortality or morbidity, but some authors have suggested that it gives you some more time in terms of getting to dialysis. So if you are far away trying to get to a center of dialysis or something, some people have suggested that when you have done all that is supposed to be done, that if you give furosemide, you may convert a non-oliguric renal failure, an oliguric renal failure to a non-oliguric acute kidney injury. And that may give some more time. It does not negate the need for dialysis. But some people have suggested that, however, it is still a controversial topic, and I don't think that it has a place, especially in septic management. So I think we have to go fast now. We have to end in the next 10 minutes. So we want us to rush the questions briefly. What doses of epinephrine and non-epinephrine in shock in children? How do you administer, and for how long can they be given safely? What are the doses of epinephrine and non-epinephrine for shock in children? How do you administer? How long can they be safely administered?
Okay, so this makes it important that every institution will have institutional guidelines, which standard operating procedures, which one could easily refer to. Maybe some of the panelists may have it off by heart, but these doses, being critical drugs, it's even better to quickly refer and co-compare with someone else when one is calculating the dose. Intravenous route, and for how long you give, you monitor till the child, as you get the child out of shock. The therapeutic endpoints are clear. We want adequate perfusion, cardiovascular system, looking at the vital signs, we want it back. We want perfusion to the brain. We see improvement in the Glasgow Coma score. And then the child who has already been catheterized, we want urine output to be more than 1 ml per kg per hour. And the child is safe to be off it, because we stated earlier that it is given for warm shock, no epinephrine, for cold shock, epinephrine. So you want to get the child quickly out because the vasopressor, that's it. But to say 30 minutes, 1 hour, 2 days, no. You don't want to keep the child as long. Shock is an emergency. The earlier we reverse the child from shock, the better.
Okay, for adults, for shock, the dose is typically 0.05 to 2 micrograms per kg per minute IV. So you start from the lower dose, 0.05 micrograms per kg per minute, and then you titrate upwards, you achieve your desired mean arterial pressure. It's typically better that you have a central line in and you're measuring the central venous pressure at the same time, so that you keep the central venous pressure at the correct one, so that you don't take the patient into pulmonary edema. That's for adults, and I think it's about the same dose for children, 0.05 to, let me just see if I have it anyway, 0.05 micrograms per kg per minute to 0.2. I don't know, Dr. Kefas, Dr. Zubair, I think I'm correct for children. So, but typically you should have one that you use for your center. For 0.05 to 2 micrograms per kg per minute IV. Give it via your solo sets, infusion pump, syringe pump, and then slowly titrate until you get the required mean arterial pressure. Of course, at this point in time, I must say that it is not something to be done by anybody. By the time you want to use non-epinephrine and epinephrine for management of shock, and you have passed the use of ordinary dopamine or glutamine, you probably should have a specialist in. Probably should call for help, call for a consultant in, and something that we do it together and everybody takes the decision together, critical care physicians and everybody. So, Kefas, do you have anything to say?
No, thanks.
Okay. So somebody asked whether we do arterial blood gases in Limi Hospital. Yes, we do. We do arterial blood gases. How do you differentiate sepsis from acute respiratory distress syndrome? How do you prevent sepsis with ARDS from cardiogenic shock? How do you differentiate sepsis with ARDS from cardiogenic shock?
Okay, fine. So maybe let's go back to the slide on cardiogenic shock, then work it back. It should be clearer. For cardiogenic shock, it's intrinsic problem with contractility. Very likely, the child, if it's easier, if the child is known to already have an acquired heart disease coming in shock, like the cardiomyopathies, or the child already has a congenital heart disease, I'll think about it, or one of the dysrhythmia. But if you look at the clinical feature of cardiogenic shock, in cardiogenic shock, there's increased pulmonary capillary wedge pressure. And that is why we have, I know this is where the question targets because of the issue of work of breathing. The child is in shock and could be in initial phase of shock, cardiogenic shock, compensated phase, cardiogenic shock. But by the time you are talking of sepsis with acute respiratory distress syndrome, that child has moved from initial, has failed compensation, gone beyond decompensation, in refractory shock. And it's also going to terminally end with cardiogenic shock and cardiac arrest. So are we dealing primarily with a cardiogenic shock, which you could meet at the initial phase, compensated phase, then these clinical features are clearly stated? Or are we dealing with any other type of shock that has had multiple organs failed? It will fail and the heart will terminally fail. So it's a two-way thing.
Okay. So I think I've answered the question. That is how to differentiate sepsis with ARDS. So there'll be fluid in the lung, and cardiogenic shock, there'll be fluid in the lung. Essentially, major pulmonary capillary wedge pressure. You pass your line in, your invasive line in, and major pulmonary capillary wedge pressure. Typically and then remember that you also do the PaO2 or FiO2. Remember the criteria, and typically you should be seeing things like less than 300 or 200, like that, between 200 and 300 for PaO2 divided by FiO2 for ARDS. However, for pulmonary capillary wedge pressure of ARDS, typically the wedge pressure should be, I think, 18 millimeters of mercury or less. And then if it's from cardiogenic shock, you should have an elevated pulmonary capillary wedge pressure, or you can easily just use your echo. If you cannot do pulmonary capillary wedge pressure, if you use your echo and you get the mitral valve transmitral velocities, you can do E over E prime. And E over E prime essentially will E over E prime essentially will show. So that's what we typically do in our center. It's easier that way. You do an echo quickly, you get E over E prime. If E over E prime is greater than 15, that will tell that pulmonary capillary wedge pressure is elevated. And what that essentially means is that there is a study by Norton et al. We tell that if you calculate the E over E prime, greater than 15 will definitely mean that the pulmonary capillary wedge pressure is raised, and that this, whatever you are dealing with, is likely due to of cardiogenic origin. Now, if it is less than 12, it's unlikely to be of cardiogenic origin. However, between 12 and 15, then it can be difficult to differentiate. And in that kind of case, the next thing you can do is to do N-terminal pro-BNP. N-terminal pro-BNP typically, which we do in our center, get your results in less than 15 minutes. But like Dr. Peter said, don't wait for the result before you start treating. You should have a clinical impression. If you have N-terminal pro-BNP greater than 300 picograms per mil, then you consider it's likely cardiogenic, and that should also be something that you should look out for. Okay, I think we have answered almost all the questions. Yes, is there a question I have not answered? Okay, there's a question from Dr. Oyewusi. One worry is tachycardia following norepinephrine and epinephrine with an already compromised end diastolic volume. Please throw more lights. Tachycardia coming in with an already compromised end diastolic volume. Please, with norepinephrine, please throw more lights.
Okay, so we are using norepinephrine for the compensated septic shock. The problem here is dilatation of the vessels, and we want to achieve vasoconstriction as much as possible. So that is where what we are targeting. Yes, end diastolic volume is already compromised, but if we can have some more vasoconstriction, we can help to get more blood into back to the into the circulatory volume. Tachycardia, tachypnea tachycardia side effect of epinephrine, norepinephrine, yes. Just like any other drug would have its side effect. You are looking at what you actually want to achieve in the type of shock. there is increased venous capacitance, which these drugs are targeting. And if it goes successfully, you get more blood into the circulation, improve the end diastolic volume. Yes, that's what I think.
Okay, great. I think we've answered that. Does the pulse pressure give any extra information about the likely cause and prognosis in shock? Does the pulse pressure give any extra information about the likely cause and prognosis?
Okay, so if we look at this slide, wide pulse pressure hypotension. This is talking about the decompensatory stages. In both cases, they are hypotensive, but the pulse pressure is wider in the warm type of shock. So you realize that there is still some gap. The systolic pulse pressure is a difference between the systolic and diastolic blood pressure. So the one that has a higher pulse pressure is warm, has bounding pulses. At that point, is still less decompensated than the child who has a narrow pulse pressure hypotension with cold, clammy extremities with rapid and steady pulses. But they are all decompensated, and there should be aggressive action on management of these children, both giving of crystalloids, vasopressor agents, norepinephrine for warm shock and epinephrine for the cold one, and then steroids, and that's it.
Okay, I'll just make a few announcements. We'll come to the end. I'll make a few announcements about CMEs for doctors and about the further things that we are doing. Just a minute. Okay, so you can see this slide. So every Friday by 3 p.m., Limi Hospital and Cardio Care, Limi Hospital Group with Cardio Care will do a Zoom webinar. Next week we'll be doing about diabetes. Very interesting. You will get a link in your email or through the way you got invited for this particular one. You can also help invite other doctors and nurses that may be interested. Essentially every Friday by 3. So the email to reach out to us is cardiocaresymposia@gmail.com. Cardiocaresymposia@gmail.com. So you can easily reach us on that email address. You can easily reach us on that email address. Now you can rewatch this presentation on YouTube, or you can go back on Zoom and re-log in, and the recorded session will be there in about an hour's time. So you go back there and then you can re-watch it from the beginning if you came late. You can also watch on Facebook. If you go to Facebook, Limi Children's Hospital, you will see the presentation here. You can rewind it and watch it again. It will be on Facebook for the next 24 hours. So you can watch it, you can share to your friends. And somebody was asking how they can share to their friends or that. So people that have missed it, you can ask them to just go straight to Facebook and you watch it. Now, every time, so Facebook, Limi Children's Hospital page. Now, every week we also broadcast on Facebook. We realize that some people are having problems in using Zoom, so we also try and broadcast on Facebook. But really, Zoom is the new thing. So every doctor should learn how to use Zoom. So for those that need CMEs, you send your full name and your full name, how you want it to appear, to cardiocaresymposia@gmail.com, the same email. And then we'll verify your attendance from the Zoom attendance sheet. And then we will receive a link to answer some questions. So the questions are going to be such that we know that you attended, not just general questions that we specifically spoke about here. So just a few questions, like 3, 4, 5 questions, you answer it, and then after that you will get your email, your CM certificate in email. Please bear with us. We are also still working while trying to organize all of this, so it's not as fast. It's not as if it is 5 minutes you get it immediately. So, but from this evening, once you get your email, once you send a mail requesting for CME, you will get a link where you will, before Monday, you get a link where you will answer questions, and then you receive your CME certificates in your email, typically via PDF, so that you can watch it. So Limi Children's Hospital is essentially located in Wuse to Abuja. You can send your patients there in case you need advice, in case you need second opinions, in case you need support. The 26-bed hospital, we have a NICU. We also have a transport incubator. So if you are delivering a preterm baby, you are delivering a baby in distress, a small baby in distress, and you're around Abuja, you can call the hospital straight away. Our address, our phone numbers are on Google. You can call them straight away, and our team will get to your center. So the baby can be delivered in your theater, can be delivered in your delivery room. Our team will pick up the baby with the transport incubator. It will warm the baby to provide oxygen. It will do everything that as if, so it will be as if from delivery to time of incubation will be less than 2 minutes. We'll help to resuscitation, and then we'll move over to Children's Hospital. This is one of our CPAP drivers for our CPAP machine. And then that is that. Now, cardio care is also one of the organizers of this program. And cardio care essentially deals with a lot of adult internal medicine, interventional cardiology, endocrinology, neurology, dialysis, nephrology. Our critical and intensive care units are very well developed here. It's in Gariki, area 11. And someone was asking about arterial blood gases. So in the cardio care, we do the arterial blood gases. Don't forget that arterial blood gases is typically very much indicated when the patient is on admission in the ICU, and you need to check the blood gases. And for these patients with the shock, and especially those who you can do the arterial blood gases straight away and know what to do. Then we have the cath lab where we also take patients in, and we hope by God's grace that we can also start correcting the pediatric defects through the cath lab. So without open surgery, Dr. Peter and Dr. Subero are standing by for us to start that process. So that is cardio care. Essentially, this is what our cath lab looks like. And we can diagnose a lot of things. Devices. These are devices inside the heart to diagnose. And of course, like I've said, this is how you get your CMEs. You can watch later on YouTube. Now, if you go to YouTube, you also find COVID and pregnancy. You also find approach to chest to difficulty in breathing. You will find approach to breathlessness, especially with the focus on COVID. And you will find COVID and pregnancy. You find some of those things there, and then you can rewatch those seminars and learn from them. Next week, endocrinology will be on talking about diabetes. We will try and put a snippet of diabetes in children as well. So the pediatricians will also contribute on something about diabetes in children, so that we can also make it very broad for you. We hope that has been valuable for your time. This is essentially brought by the Limi Hospital Group, and of which Children's Hospital is one of them. Limited Hospital is one of them. And essentially, we are just trying to see how we can work with other doctors to give them what is necessary for to help presentation, to help taking care of patients. Now we know that Nigeria has its issues, but I feel that if all of us work hard at different things, we can help Nigeria to be quite well, and that's what Limi Children's Hospital are trying to do. I want to thank Dr. Peter, Dr. Kefas, and Dr. Subero for their fantastic presentations. I want to thank everybody that joined up. I'm sure you had wonderful, you had a good time with a lot of stuff. That was a lot of stuff. Even me, I really enjoyed it. Thank you, Dr. Peter. Fantastic. We'll also be talking about neonates, I think, in 2 weeks' time. So we'll do it in neonatology and resuscitation. I think Dr. Kefas will be handling that. I can see Dr. Oladele, consultant pediatrician, saying, good job, well done. Don't forget to mention calcium in shock. Don't forget calcium in shock. Good inotrope. It gives some synergism to some drugs in shock. Okay, so I mentioned it now as well. Thank you all. I think I've answered all the questions. I wish you a very nice weekend. Have a great time. Please try and make sure you tell other people about this so that we can really help Nigeria. If this knowledge is what will change Nigeria, it's not so many things. I don't think we have much more to do about the political situation. But what we can do, we can give patients the best. And God bless you all. Have a nice weekend.